Hi, this is Junaid, back with another lecture on Acute Ischemic Stroke 2019 Guidelines Review. In this lecture, we're going to discuss general supportive measures and emergency care. The current guidelines are divided into 6 as we discussed before, and this is the part 3. In this particular lecture, we're going to discuss points from 3.1 to 3.4, which is going to discuss blood pressure management, temperature, airway, etc. So first and foremost, as anything in medicine, we have to make sure that the ABCDs are followed. We have to make sure that the patient have airway management before we actually even go ahead and think about stroke. Especially in our stroke patients who have bulbar dysfunction, possibly decreased consciousness, we have to make sure that their airway is secure. Again, the level of evidence will never be high because you're not going to study this into a randomized control trial, but the class of evidence is one. The second point comes in with supplemental oxygen. Those patients who actually have hypoxia, you should consider improving their oxygenation status in terms of improving up to a level of 94%. However, this, as I said, these are guidelines. These are not biblical, decree or legal decree. You have to understand that if the patient has known history of COPD and is living at 88%, that might be okay for that particular patient that you're taking care of. So it is important to understand that all these guidelines have to be in the context of your patient, and therefore supplemental oxygen should be given because the patient might actually have bulbar dysfunction, decreased consciousness, etc. But if the patient actually is not having all those things, however, is hypoxic because of a baseline COPD, that might be a different story. So that's one of the things that you have to always consider when you're looking at those things. Supplemental oxygen in non-hypoxic patients. Do not waste time. It does not help. That is something that has been studied, and therefore it is recommended not to go ahead and do it. As you can see, the level of evidence is B. So we have some studies that shows that we are going to waste time doing that. So it's not recommended. Similarly, hyperbaric oxygen, people have tried that. We have clinical studies that have not shown any improvement in using hyperbaric oxygen. So there is no role of hyperbaric oxygen in acute ischemic stroke treatment. Now we move on to the blood pressure goals. The blood pressure goals is important because the key issue with IVtPA that the risk is the bleeding in the brain. And therefore, before initiating the bolus, your systolic blood pressure should be less than 185. The diastolic is always something that I personally also struggle with. At the end of the day, if you're going to lower the blood pressure to systolic less than 185, the chances are that the diastolic is going to go less than 110. To be honest with you, the way we measure blood pressure is the most haphazard way that we do anything in medicine. As a matter of fact, all the autonomous blood pressure cuff measurements actually do measure MAP, and then they split it out mathematically into a systolic and a diastolic. So at the end of the day, what you're really treating is a MAP. So at the end of the day, what I'm trying to say is that make sure that the systolic is less than 185 and diastolic less than 110 would be ideal before initiating a bolus. Once the bolus is initiated, it is make sure that it is maintained less than 185 according to the new guidelines. People do prefer less than 180. Actually, the idea is to give you some room of error rather than anything else. And lastly, am I supposed to ever improve blood pressure by using drugs like iatrogenic medications to improve the blood pressure? The current recommendations actually is important to consider that if you actually truly have hypotension, you may consider it. However, it is not well established. However, if the patient is clearly hypovolemic, clearly hypotensive, you have to treat it anyway. So for example, if the person is coming in with a systolic of 80/50, what are you going to do? You're going to at least increase the MAP above 65. So my theory has always been if you're going to make sure that the MAP is above 65 and preferably above 70 for all patients that are coming in with acute ischemic stroke. Now, am I going to push after that? Generally speaking, I don't see the good reason because I feel like the chances of having a significant bleeding event in terms of maintaining blood pressure is high. So generally speaking, I do not prefer putting patients on iatrogenic medications to improve blood pressure. However, if they're clearly too low, you should consider it. And the benefit definitely is not well established. The benefit established on do not avoid hypotension. Well, it's not that established either because if you look at the level of evidence, it's still not good. But if you look at the class of recommendation, avoid hypertension, avoid hypovolemia, and if you have to sometimes use drugs, do it. Now let's move on to temperature. If you look at the actual neurological problems in general, if you see the whole gamut of data from intracerebral hemorrhage, subarachnoid hemorrhage, everything, increased temperature decreases good neurological outcome, no questions asked. This is very, very significant. As a matter of fact, if you look at the data, higher temperatures are consistently showing that the neurological outcome is bad. So is there good evidence? No, these are all retrospective studies which are done, with these things in mind. However, the independent predictor of temperature is not to be disregarded. So if your patient is having a temperature, treat it. It is not a contraindication for giving TPA. Let me be very clear. Having a temperature is not a contraindication to give TPA. However, what you have to understand is making sure that to achieve a good neurological outcome, you have to decrease the fever. In acute ischemic stroke patients, induced hypothermia is uncertain. Now, this has been an area of active research. Hypothermia induction through skin-to-skin contact has been one of the mainstays to decrease the metabolic demand on the brain. And when you're decreasing the metabolic demand on the brain, then if there is a decreased flow of the blood, chances are that the brain itself is not going to be harmed as well. The problem always comes down to that is whenever you do hypothermic therapy, you're producing a lot of problems, arrhythmias, coagulopathy, etc. And people are actually looking at special helmets, special nasal implants to actually do only cranial hypothermia. At the end of the day, this is under investigation, and this is something that we don't know and we are uncertain about it. And hence, the level of evidence is B and the class of recommendation is 2B. So now let's come to blood glucose. Hypoglycemia is a stroke mimic. Let me repeat that. Hypoglycemia is a stroke mimic. So if you actually have a person who's coming in with blood sugars less than 60, to be honest with you, that is a contraindication to give TPA. Not only that, the second thing is you have to treat it urgently and emergently to decrease risk of having permanent neurological damage in these patients. So avoid hypoglycemia, treat hypoglycemia as soon as possible. Similarly happens with hyperglycemia. Hyperglycemia, again, like hyperthermia, is consistently shown that you could have worst outcomes in all neurological problems, GBS, intracerebral hemorrhage, subarachnoid hemorrhage, acute ischemic stroke, everywhere. So you need to avoid hyperglycemia, but a very tight control has shown in multiple studies, including ICU studies, that the patient do not do well. So because the problem really is when you have a very tight control, you end up having hypoglycemic episodes. And that is even worse than hyperglycemic episodes. So you have to make sure that you find the right balance. You treat the hyperglycemia, you maintain it less than 180, but making sure that you do not get hypoglycemic episodes. Thank you very much for taking the time to listen to this lecture. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.